Hello, hello, everyone. Welcome to another Wednesday VMR, and Merry Christmas to anyone who's celebrating and happy holiday. Thank you for choosing to spend your morning with us. We always are incredibly grateful, and you're in for a treat. We have the one and only Prof. Rez helping me discuss today, and we have a case by one and only Kurtan. Kurtan, do you want to say hi?
Yes, hello everyone. Thank you so much for joining on this wonderful day. It's Christmas. I'm always so excited in the festive spirit to present the case. And I was just talking to Sharmin and Reza in the background that how hard it is to schedule the case. And I haven't seen Sharmin for at least 5 years and Reza for at least 1 year. So the last time I presented case to them was way back. So I thought this is a perfect opportunity to rekindle our bond. So it's going to be great. And last time I presented case on Christmas, it was like 4 years ago, and it was great because we themed it in the Christmas way, like gave the title, which was like Christmassy. So I also tried to find the same thing today, that I chose a case which is so Christmassy in a way, and I'm sure all of you will enjoy. I also personally learned a lot from this case, and it's going to be great. So thank you so much to everyone for joining. Thanks to Anmol Preet for helping with teaching and Bayan for scribing. And maybe I can pass the mic to Rez. How are things going, Rez?
I am doing really well. I'm actually doing better now, Kirtan, that I know I'm about to co-discuss a case that you're presenting. And Charmin and I are in a very festive spirit, so I think we're going to do well. Merry Christmas to everyone who celebrates.
Oh, I'm so excited for this. And yeah, shout out to Amol Parade and Bayan for doing scribing and teaching points. And if you all can get the board up, we can get this party started.
Perfect. And Rez and Sharmin, this case is, how to say, a little bit longer. So maybe I will try to pace the aliquots in that way because there is more information coming in the later half. Okay, perfect. So let's get started. So the title of the case is The Shining Sparkle. And now the first aliquot we have. So I have divided the case the way patient presented and the way things evolved. So everything gets done within 2 weeks. So we will start with week one on the Monday, which is when the story starts. So week one, Monday, we have a 30-year-old, very pleasant gentleman who goes to dinner with his friends and he eats chicken, beef, pizza, cake, and juices. And on the same day, two of his friends develop nausea, vomiting, and diarrhea. Our patient is actually fine on Monday. Then on Wednesday, so 2 days later, he experiences fevers, sore throat, drenching night sweats, nausea, vomiting, non-bloody diarrhea, gets prescribed oseltamivir and ibuprofen for suspected flu on Friday by PCP. However, his night sweats, anorexia, and nausea and vomiting was so profound that he cannot keep even a sip of water down. That's why he decided that now it has almost been 5 days from Monday to Friday. So now it's time to go to the hospital. So he comes to our emergency department. When you examine him in the ED, he tells you that apart from night sweats, nausea, vomiting, and diarrhea, he also has intermittent left upper quadrant pain, which is worse on taking the deep breaths and on movements. Additionally, over past 2 days, he has been having diffuse throbbing headaches, which are rated as 7 out of 10 and which doesn't have any exacerbating or relieving factors. Apart from that review of system, all the negative things. So he denies prior similar symptoms, conjunctival redness, yellowing, rhinorrhea, blurry vision, hearing changes, aphthous ulcer, dysphagia, odynophagia, rash, dysuria, hematuria, hematochezia, or tenesmus. So all these are negative results. And this is the end of fossil equation.
Charmin, I don't think there is a symptom that wasn't mentioned in this first aliquot. You know what I'll do is I will do my best to discuss this first aliquot and then ask Charmin to just layer upon that. Because I think the reason I say that is because there's so many ways you can take this first aliquot, and we'll do our best. But remember, this is sort of an artificial simulation in that we don't have any laboratory data, we don't have any imaging. So it's going to be very hard to come up with a crisp problem representation. And oftentimes in medicine, but I first want to say this. When I was 32, not 32, but 32, TOO, I would order pizza with a steak sub, French fries, and a cake. And I would do exactly what these young young people did. But I think what's really important here, Kirtan, is that it's so easy to blame everything on the food. Either the patient might blame it on the food or the providers might blame it on the food. But you have to be cautious there because we do have a sequence of events, but we have to realize that the human mind has recall bias. Meaning, talk to any Persian out there and they'll tell you why they're feeling sick. Because last week I went and played tennis and the car window was down and the air hit me in the face, and that's why I'm presenting with knee pain. It's like, I don't think that's related. There is a possibility this is related, but I think you have to be careful with assigning blame because how could this be related? It would be some kind of food-borne illness, but we know those are short-lived and they usually don't present with such inflammation, headache, pleuritic chest pain. No. So what I'm actually going to do is I'm going to completely ignore what happened a few days prior at this moment in this aliquot. And I'm going to ask myself, there are so many symptoms and systems involved. Where should I focus on? Well, there's a general theme here of inflammation. When someone has night sweats, you better believe that they are inflamed. So I have inflammation, and we know for inflammation the eye made mnemonic, and we know we always start in infection. So I put that in the back of my mind. And then I say, of all these symptoms, which one is to give me the highest yield in terms of a differential diagnosis? I'll tell you, it's not nausea and vomiting. It's not even headache, because oftentimes nausea, vomiting, headache are just bystander to a systemic illness or a multi-system process. Here, honestly, what grabbed my attention the most, based on the first aliquot before the exam, before the labs, is that left upper quadrant pain that worsened with inspiration. And maybe at this point, I can ask Sharmin just so we can have a dialogue. I was just curious for you, of all these symptoms, where are you focused, knowing that it's multi-system, it's inflammation, but where are you going to put as your center of discussion?
Yeah, I 100% agree with you, Raz. And as you mentioned, I think like with the nausea, the diarrhea, all of these are non-specific symptoms. So, and we don't have any other data. So the one that we can probably make the most progress on is abdominal pain plus inflammation. So thinking about is, and it might not be, right? Like we might get more information and change our mind. But if I have to frame it, I would say like, oh, this is a guy coming in with left upper quadrant abdominal pain and inflammation for 2 days. And for now, just imagining the nausea, the vomiting, the diarrhea being a sequela of the abdominal pain. However, with the fever, with both like the fevers and also like worsening headaches, you don't want to miss like any intracranial process. And I totally agree with you, like the food, just like, I feel like a lot of the times, like exposure history as well in your day-to-day life, they're just like red herrings, but in CPSs they're often not. But the other thing that I was just thinking, I was like, or if he had sometimes a foodborne illness or viral infection, could we possibly dealing with a sequel of that? Like, did they set off an autoimmune response to an infection that we're dealing with? So that could be a possibility, that it's just like unmasking an underlying autoimmune phenomena that we've yet to discover, especially in someone who's like in their 30s. I feel like that could be a possibility. In terms of like a it was left upper quadrant, right? So yeah, left upper quadrant. I feel like the big one there is like the spleen. If this patient for whatever reason has splenomegaly, like bowel runs through it. And I always like think about the thorax and the diaphragm as well. If you're dealing actually with any intrathoracic stuff that could be happening. Although like, the atypical presentation of abdominal pain are very common. And, someone who is this inflamed, we're going to go through the tube of truth at some point, I feel like. Anything else to add, Raz? All right.
Perfect.
Back to
You
you,
guys,
Kirtan.
Oh, actually,
Perfect.
let
You
me just
guys
add one
are
thing.
nailing.
I see Robbie's name there. I just want to wish Robbie a Merry Christmas.
Perfect.
Excellent.
Uh,
Thank you, Prophet.
you guys are nailing it. It's you could imagine that if somebody is retired and just staying at home, and if you ask them when did your illness begin, they probably won't be able to tell you. But if somebody's life is filled with adventures, like they are going to party one day, they are going to skiing other day, then they will always remember that yeah, maybe this symptom came right after skiing, right after partying, but it has got nothing to do with that. It's just a moment in time. So you guys are absolutely right. That is very vital piece in clinical reasoning. So second aliquot, past medical history and medication wise, everything none. Patient has never been to any hospital before. He just received a flu vaccine 2 weeks ago. So we are talking about Monday of this week. So Monday, 2 weeks prior, he got the flu vaccine. And right after getting the flu vaccine for couple of days, patient was feeling sick, like fevers, chills, but then it went away. Uh, Regarding social history, he occasionally vapes, but no smoking cigarettes, no alcohol, no injection drug use. He came from India 1 month ago. So he is an engineering student in one of the universities here in Chicago. And he last went to India 1 month ago. After coming back from India, he was fine. He had no illness and he doesn't recall any kind of bug bites back in India. He doesn't have any pets at home. Talking about vitals in the ED, so he's febrile at 39.2 degrees Celsius. He has tachycardia with heart rate of 135, respiratory rate of 22, saturating at 98% on room air, and blood pressure normal, so hemodynamically stable. On examination, you find that he is very tired looking, fatigued, worn out, very unwell. You can see the beads of sweat dripping at the forehead. He is nauseous. You auscultate the lungs, they are normal. You look in the oral cavity, no lymphadenopathy, no redness, no ulcerations. You look at the eyes, no pallor, no icterus or no conjunctival suffusion, no murmurs on auscultation of heart. You do experience the tachycardia. Left upper quadrant fullness and tenderness is evident, but otherwise abdomen is soft and non-tender, no fluid wave seen, no rashes anywhere on the skin, no edema and no clubbing. You proceed to obtain some basic labs. So BMP is within the normal limits. CBC, hemoglobin 15.3, MCV 85, WBC 15.1 with 77% polymorphs and 11% bands, platelets 172. You get the liver profile. So AST slightly elevated at 43, ALT 28, normal limits, LDH 220, which is just 10 points above the upper limit of normal in our lab. Alkaline phosphatase, GGT, bilirubin, normal limits. BUN, creatinine normal, total protein 7.3, albumin slightly low at 3.4. Urine analysis shows 2 plus blood with 30 RBCs, 3 WBCs, and 100 protein on dipstick. And this urine sample was collected without any catheterization. It was a clean catch midstream urine sample. And that's the end of second article.
Wow. Thanks so much, Kirtan. I'll comment a little bit of a history and the vitals, and then I'll pass the mic to the Prof. Raz for poetry. So, in terms of like kind of the background information, kind of unsurprising that like a 30-year-old doesn't have a significant past medical history. One thing to note for whenever a younger patient comes along, and not necessarily like you don't need to do this in the first pass, but if we start to get a flavor that this might not be infection, that is more autoimmune related, it might be worth getting a little bit of a family history, especially about any like potential diseases that runs in the family. But again, like the nice thing about people coming inpatient is that you'll always have a chance to go back and ask more questions. So that's something to know depending on how that case go if you need to get some additional information. In terms of the social history, very informative with the travel history a month ago. So, the question is always like, is this travel related or not? Oftentimes, one thing that I would note with people traveling back, I'm not sure if he at any time lived in India, went back for a visit. Like if I go back to Iran right now, I've like gotten so used to my microbiome has gotten used to being in America, and but I will like go back and do the things that I used to do there. And it's probably going to get me in trouble because I'm not the same person I was when I haven't been back in like 10 years. So that's something to note about, like, if you're thinking about exposure history, food intake, or anything that could be pertinent. And, uh, I, and Profess, I love his fever and returning travel schema that is on our website. What I love emphasizing is that, while like travel history at times is a red herring. So thinking about like this patient still has the right to have any local infection, autoimmune diseases, any malignancy, all of those things, and also it's worth a thought about like whether this could be travel related. And now a month later, it really, really, if this is related, is like the ones with longer incubation time. So your TBs, HIV, so like those diseases that can have longer incubation periods are the ones to kind of think a little bit harder about if this turns out to be related to the travel. The flu vaccine, again, I'm not sure what to do with that information, whether that could be a potential trigger for an underlying autoimmune disease, potentially. But again, chances are it might not be related. In terms of like the vital sign, the one thing that caught my eyes again, the fever, and we're expecting that with like the drenching sweats, and your description of him being very diaphoretic is very notable. What to do in that heart rate of 135? Again, in a 30-year-old, I think that's just a response to his inflammation and illness. If he was like 90-year-old with 130, a heart rate of 135, I think my calculus would be a little bit different. I suspect that he's like pretty dehydrated, but if he's having a solid blood pressure, I think he can handle the heart rate in the 130s. Rez, what else jumps out to you?
Charmaine, I'm just really impressed by the use of the word microbiome. Like that's really impressive. And like how if we return to Iran, you're absolutely right. We'll probably have a GI distress from eating too much local kebab. Um,
Now I'm just getting hungry.
it's so interesting. I think when you have a case like this, you have to really remember what are the most telling symptoms or the most telling laboratory abnormalities. And I think in that first aliquot, we focus on the abdominal pain that was pleuritic in nature, left upper quadrant with the background of inflammation. And I think what the labs do for me is add further credence to inflammation with the neutrophilia, where when you're inflamed, you get demargination of these mature neutrophils ready to attack, the organism or respond to a stressful state. Additionally, another marker of inflammation is the fact that the albumin is low because it's a negative acute phase reactant. There might be a slight protein gap, likely polyclonal in nature. But I think what's most striking here is the UA. But before even focusing on the UA, we have to address the AST being slightly elevated, the LDH being slightly elevated. And I think most of us would say, well, is this liver or is this extrahepatic? And we have to consider extrahepatic, specifically hemolysis. And you may say, wait a minute, how do you have a normal hemoglobin and hemolysis? Well, remember, this guy has been vomiting and has been keeping zero PO. So probably that platelet count, the white count, and the hemoglobin are an overestimate of their actual values, meaning that we might actually have a bicytopenia here, being an anemia and a thrombocytopenia, which should prompt us to get a peripheral blood smear and think about the possibility of hemolysis, but not only hemolysis, microangiopathic hemolytic anemias. Before we rush down that pathway, we may have to activate that schema and think about our MAHAs. I think a smear, a haptoglobin would be helpful test to have. Now, the UA, you may say, well, the creatinine is normal, so why worry about the UA? That would be a huge mistake because you can absolutely, in fact, most glomerular nephritides, or many of them, don't cause AKI initially, meaning AKI will eventually come, but initially you may have a totally normal creatinine. So if you have a patient and you're worried about lupus and the creatinine is normal, but you see protein in blood in the UA, you must be worried of a glomerulopathy but an inflammatory glomerulopathy being glomerular nephritis. So I would trend the UA, but I would also get microscopy on it, looking for red blood cell counts and dysmorphic reds, because maybe the problem we're solving is a glomerular nephritis, and that would be a very important clue and have a lot of specificity in terms of diagnostic power. So I think what I would do here, Sharmin, is I would say, okay, we need a CT scan with contrast. I'm not even worried about the kidneys because I'm more worried about what's happening in the left upper quadrant. I would get the chest and the abdomen and pelvis because of the pleuritic nature. That could tell us that this patient has pleuritis. They may have something going on in their spleen. They may have splenomegaly. But I would also get a smear to see, am I dealing with a MAHA? And I loved what you said, and you reminded me, young people, what are they at risk for? Beyond, infection, autoimmune diseases, and genetic stuff. And this patient has had a stimulation to their immune system, being the flu vaccine that they received 2 weeks prior. So I'm not ready yet to actually list a differential diagnosis or share a schema on glomerular nephritis or bicytopenia or microangiopathic hemolytic anemia, but all of these thoughts are crossing through my mind. And I think the next steps is a pan CT scan with contrast, a peripheral blood smear, and just seeing what this UA tends to show us to see if we are dealing. And I would get a spot protein to creatinine ratio, and I would start thinking, am I dealing with a glomerular nephritis? I'm just curious, Charmin, any reflections on that? Anything to add before we get more data?
No, that's absolutely brilliant. I absolutely agree with you. And I love the fact that you're like, I'm not ready to share a differential because I think we're still trying to define what the problem is that we're trying to solve. And that was just absolute poetry, Prof. Rez. I can listen to you discuss cases all day long. Back to you, Kirtan.
Perfect. So firstly, I just wanted to highlight that how inspiring it is to see you guys discuss, because like whenever I discuss, I will always, after the end of my discussion, I will ask Rabi for feedback that how did I do? And if I was in your position at this time, I would be so overwhelmed that probably I would get fixated on one left finding and will list the differential for that. But like what you guys are doing, that you are not missing any details. You highlighted the travel to India, you highlighted the flu vaccine, you highlighted the diaphoresis, tachycardia. So this is something which I hope that I can do it more and more in the future, that to keep everything in perspective and still have the big picture as well, that what's the next step. So you guys right on the money. This is similarly what we were thinking in the real time, and this is what we got in the next record. So week one, and on Friday he presents, and now we are talking about Saturday or Sunday. His condition is still same, unfortunately. Nothing is budging. His fever and tachycardia continues, and I have never personally seen this much tachycardia in somebody. So since coming to the hospital, his lowest heart rate has been 125 and highest has been 160. For never even one moment or one reading, the heart rate went down below 125. The fever, on the other hand, it comes like once or twice in a day, it stays for a few hours, then it goes away. But even when the fever goes away, the heart rate always stays high. So, which is one of the findings which I wanted to highlight. What other things have been happening in general? So, he still has the left upper quadrant pain. He still has some nausea and vomiting. Diarrhea has resolved as of now. He still doesn't have any rash, but he noticed that while swallowing water, he was having some pain. So he looked in the mirror, and we also examined him, and we found that on the left lateral aspect of the tongue, we found one tiny aphthous ulcer. There was no blood oozing out. The gums looked good. The other teeth and everything looked fine. And no neck tenderness, no neck swelling you could appreciate. Still no erythema at the back of the throat. But you do see that there is one aphthous ulcer. At this point in time, since he keeps on having fever and tachycardia, and we will get to the CT scans, but in the ED, of course, he got the chest X-ray and abdominal X-ray, which was unremarkable, couldn't find anything. But they thought that, hey, he is febrile tachycardic. He deserves at least some round of antibiotics. So he gets vancomycin and zosyn, like piperacillin tazobactam, for 1 or 2 days. Blood and urine culture so far unremarkable, and you could imagine that he is having fevers multiple times, so he is getting blood cultures multiple times as well. So right now we're talking about three set of blood cultures all negative, two sets of urine cultures negative. He gets the basic microbiologic testing, respiratory viral panel, which in our institution includes influenza, parainfluenza, adenovirus, respiratory syncytial virus, human metapneumovirus, COVID, all negative, HIV, hepatitis A, B, C, E, syphilis screening, unremarkable. Finally, he gets the CT scan. So CT scan shows that he has hepatic steatosis, and this gentleman's BMI is probably 35. So he has hepatic steatosis with hepatomegaly, mild splenomegaly, scattered prominent retroperitoneal lymph nodes, but no overt lymphadenopathy. Lungs are clear. There is no evidence of pulmonary embolism and no evidence of infiltrates, pleural effusions. CBC, what about labs so far? So CBC is still hanging around there. His WBC fluctuates between 15 to 20, still neutrophils, still you see the bands. A peripheral smear was obtained just to make sure no other parasites or anything is missed. Peripheral smear was unremarkable. No cystocytes or no inclusions in the RBCs or WBCs were seen. What about the liver profile? So liver profile is slightly getting deranged more. So AST was 184, ALT 92, LDH 353, ALK-phos, GT, bilirubin still within the normal limits. And what Prof. Rez was asking for, we also got the CK, creatinine kinase, making sure there is no concern for rhabdomyolysis contributing to LFT abnormalities. So CK was within the normal limits. Urine analysis, we repeated it like 3 or 4 times at different intervals just to make sure that findings are consistent. And all of them showed consistent findings that he would have some proteinuria. On quantification, it was about 1 to 1.5 grams, so subnephrotic. He will have about 10 to 20 RBCs in all the urine samples. He will have 2 plus or 3 plus blood as well. And we eventually spinned it as well, and they were dysmorphic RBCs. So UA has been same consistently. And so while this all has been going on, we reached the week 2. So in the week 2 on Tuesday, so now we are talking about 8th day from the beginning, he develops severe stabbing chest pain, and which is worse on lying down. And this is the end of third aliquot.
Charmaine, wow. Kirtan, you're presenting this story so well, and it's like always such a joy to have someone with your expertise present us a case. Thank you. I don't know how festive my mood is, though, based on how much data you're presenting us. You're turning me into the Grinch as opposed to making me festive. But Charmaine, maybe I can hand you the mic because I spoke a lot in the last aliquot. Have you discuss, and then happy to discuss on top of whatever you say.
Yeah, absolutely. Yeah, lots to dig through. I'm still trying to figure out where the center of gravity is and what the problem I'm trying to solve is. So, again, this patient is inflamed. He has like mild splenomegaly. So uh, I'm really grateful, like the HIV, all the testing that they've done, it's negative. So I was like trying to think, I was like, okay, splenomegaly is not normal, right? Why is this patient has splenomegaly? So sometimes I'm like, when I'm like stuck, I'm like, okay, let me take different individual pieces and see how much progress I can make in each one of them, right? So with the splenomegaly itself, I'm like, okay, and the lymphadenopathy, right? Like I'm like, oh, what is going on in there? What is infiltrating that is making the lymph nodes bigger? That is making the spleen bigger? Are we dealing with water? There's no evidence of like water, right? Like he doesn't have ascites, his liver is doing okay, so probably less likely. And then we're left with like white blood cells, molecules, and like RBCs. I really loved your thought on on hemolysis. And the one thing that was like came to my mind with like kind of the cyclic patterns of fevers was like kind of malaria. Like so, getting a thick and thin smear would be a good idea in this patient. The other thing to always like know when people get hospitalized, oftentimes people get on scheduled Tylenol, so you might miss a lot of fevers. So if you're worried about not catching it, just make sure you don't add Tylenol to the med list because people get it and then you forget to double check. So I think like Yeah, like infection, like malaria, especially given the travel to one is to think about, like molecules like, amyloid and stuff. I'm not ready to go down that path yet. And then becomes like, any infectious etiologies, like, mono, like can present like this. HIV was negative, but EBV can do similar things like tick-borne illnesses, probably less likely. And the other thing that, I don't want to miss is like granulomatous diseases because they tend to be sneaky. So I think whatever this patient has is sneaky. So I'm not worried about like a pyogenic unless like it's like a kind of culture negative endocarditis as much. But something like granulomatous diseases, like, with the lymph node, with the spleen, it's something that I don't want to miss, like TB being notorious in that. And also like, you know, lymphomas is another one to think about. And then like autoimmune diseases, sorry, autoimmune diseases, again, I'm not like ready to pull that trigger yet. I think if I'm evaluating this person, if I was in Kirtan's shoot, it would be infection, infection, infection until proven otherwise. And I do wonder if this is someone you would go after tissue sooner than faster. I'm not sure. You can like send serologists, but I wonder if tissue will be the issue and if any of those lymph nodes are easily accessible. I might ask like our IR to see if we can get like at least like a core to start with. I'm gonna stop there and then I'll have you layer on the chest pain.
Yeah, thank you. I think that's so helpful, Charmaine, to anchor yourself in splenomegaly and use that as a jumping point. I think what the chest pain did for me was that it made me wonder, is the pericardium inflamed? And so now we have the spleen that seems to be swollen, and he swallowed something and it hurt his esophagus, really specific for, assuming it's not oropharyngeal, for odynophagia, and odynophagia translates to mucosal inflammation. So I wonder if he also has esophagitis, if he has pericarditis, and if he's just having inflammation of multiple mucosal layers. Because with pericarditis, when you lie supine, the chest pain is worse. When you're upright and lean forward, it feels better. So that would prompt me to actually get an EKG. I'm sure Kirtan has one, and I'm assuming it's sinus tachycardia, but that's just my assumption, and a troponin level. Because once you start entertaining pericarditis, you wonder, is the myocardium also involved? And for someone who's going so fast, you may miss, a slight decrease in EF that may manifest as pulmonary edema. So I would get a troponin, I'd get an EKG. I would add pericarditis, honestly, as a working hypothesis to the list of problems that this patient has. And I think the splenomegaly would be a good explanation of the pleuritic left upper quadrant pain. So now we have what seems to be the gastrointestinal system, the spleen, possibly the pericardium, maybe the myocardium, and the glomerulus. I think the glomerulus, we know when you see dysmorphic reds, it's basically these red blood cells going through an inflamed glomerulus, and they take on a Mickey Mouse shape. And because when they're going through this inflamed glomerulus, they become dysmorphic. That has 100% specificity for glomerular nephritis. So now we're ready to share our schema for glomerular nephritis and seeing if any of those diagnoses may explain what's happening at the level of the pericardium, at the level of the gastrointestinal tract, including the tongue. Remember, mucosal, he has an aptus ulcer, and at the level of the spleen. And when you go through the GN, it's good to break it down into immune complex, ANCA, and anti-GBM. Interestingly, anti-GBM, which is Goodpasture syndrome, was named after Dr. Ernest Goodpasture during one of the flu pandemics. And it was really the flu that, triggered the antibodies that targeted the glomerular basement membrane that exists on the alveoli and in the glomerulus. But I don't know how that would explain what's happening in the spleen, what's happening in the tongue, but I would still send the anti-GBM serology. I would send the ANCA serology. I would send complement levels because when you're in the immune complex, it's either hypocomplementemic immune complex mediated GN or normal complementemic immune complex mediated GN. And in that category, if it's the complements are normal, the glomerulus can just be a bystander, believe it or not, due to IgA glomerulopathy, and that can always occur in the setting of like an inflammatory state. But it brings to consideration stuff like endocarditis, lupus, post-strep GN, all those stuff. I would send an ANA at this point, for sure, because like lupus would be unusual, but it can cause ulcers. It can cause the thing that lupus wouldn't cause is a splenomegaly. So maybe that's less likely, but I would still send an ANA nevertheless. I would send the ANCA serologies. And now the glomerulus being inflamed, you now have some urgency. And oftentimes these patients do require a biopsy to look at light microscopy, immunofluorescence, and such. But the other thing I was going to mention is this rising LDH, the rising AST is really making a strong case for hemolysis. The lack of schistocytes make MAHA less likely. And now you wonder, is this immune-mediated hemolysis? So I would send the Coombs test to see if it's positive, and is this a DAT positive hemolytic anemia? And then if it is positive, we can start thinking about stuff that cause warm and cold autoimmune. This is more of a flavor of warm to me. And with the lymph nodes that are retroperitoneal, even though they're not enlarged, but they're there, they may become enlarged tomorrow or after tomorrow. So you have to think about retroperitoneal lymphadenopathy. And when you think about that, you have to consider lymphoma. And I think lymphoma can definitely cause splenomegaly. It can infiltrate various organs, and it can cause a warm autoimmune hemolytic anemia. So I think honestly, what really concerns me, by the way, the ulcers and lupus are usually painless, not painful. But I also thought about IBD because of that aphthous ulcer, and could this be extraintestinal inflammatory bowel disease? But the spleen stuff makes me sort of pause there because the spleen is mildly enlarged, but I'm not dismissing that possibility. So I think what I would do next is I think the kidneys, they must be explained. I would get that EKG, I would get that troponin. I'd be very careful about the heart. It seems like we have a multi-systemic inflammatory disease with a tropism for mucosal surfaces and the reticuloendothelial system. And this may end up being an acronym of some sort when the case ends, because we're starting to say, oh, there's a GN, there's a spleen that's enlarged, there's an ulcer. But that's as far as I can take it. I don't think I would continue antibiotics because they're not helping the patient. And that's I don't think it's a common bacterial infection that's at play. But I would be wondering if we need to do a kidney biopsy at this point, because I think the case for GN has been confirmed with the dysmorphic rats.
Raz, can I ask? You're so brilliant. Can I just ask you? Maybe this is a gap in my knowledge. I've actually haven't seen GN without AKIs. Like oftentimes the GNs I see have like worsening AKI rapidly progressive. So like, but this patient has dysmorphic red, so maybe like the kidney injury will come in a few days. Maybe we're just catching it early. How are you thinking through that
Thank you
for
for
my
asking. I think
education?
this is such an important question, Charmine, because I remember I was faculty at Hopkins, and they had presented a young woman with red blood cells in their urine and protein in their urine, but a normal creatinine. And I said, oh, this can't be a GN. And then my friend Manny, who's a nephrologist, said, Reza, no, no, no. You don't need to have an AKI to have a GN. And if the case is made through proteinuria, hematuria, and confirmed through microscopy, then that can be a glomerular nephritis. So I would say this, I would say like the lack of AKI doesn't lessen my concern for a GN, especially in the context of proteinuria, hematuria, and dysmorphic reds.
That's such a great pearl. Thanks, Prof. Raz. All right, Mike, back to you.
Perfect, friends. So you are on the right path, and this is what happened next. So in this aliquot, I will combine last two aliquots because we are nearing the end of the time. And at the end of this aliquot, you guys can tell me that what's your final thought, what's the final diagnostic test and everything. So let's get started. All right. So given that he had this chest pain, and as Prof. Rez said, and Sharmin alluded to, that this could be coming from pericardium. So eventually we got the EKG. EKG shows that there is diffuse SC segment elevations. The examination showed pericardial friction rub. troponin were obtained and they were elevated at 0.712, then downtrended to 0.553. BNP levels 348, 360, so kind of hanging around there. CT scan, repeat CT scan was obtained because since his tachycardia keeps on getting like always there and even more worse now. So the repeat CT scan doesn't show any pulmonary embolism. Still, chest is clear, no infiltrates anywhere. But we did notice that there was fat stranding in the pericardial recess concerning for pericarditis. And we also got the cardiac MRI. And cardiac MRI, I can share the image really quickly because we don't get a chance to look at cardiac MRI much, but these images are really cool. So maybe I can show you. Hmm, okay. This is the first set of image.
Yeah, Kirtan, you're gonna have to teach us, man. I have no I just can see that there's a heart and a pericardium there.
Yeah, even I am like so bad at this, and I apologize if any cardiologists are seeing this and they will think that what is even Kirtan speaking. But at least we can see that at the margin of the heart, you can see that this bright, shining light, like kind of line there, which is there, like, kind of sparkling as such, right? So that shows that the parietal pericardium is very inflamed. And if you can see near the aorta side, so in the bottom side of the screen, if you can see that a little bit of enhancement is spilling in the myocardium as well. So parietal pericardium is diffusely lighting up, but the myocardium is lighting up patchily as well. So some, as Prof. Rez was saying, that if there is inflammation in the pericardium, it would spill probably to myocardium as well. And then probably one more image I will share. So here also on the upper side of the screen, you can see that this part, there is this enhancement in the parietal pericardium. So which kind of is telling that there is diffuse pericarditis and at the same time patchy myocarditis too. Although his hemodynamics have always been stable and we obtained the transthoracic echo at two different times. First, we obtained it for the concern for endocarditis and second time we obtained it because of what Prof. Rez said, that could this be something like giant cell myocarditis, which is progressing so fulminantly in the setting of systemic illness that which is making this patient sick? But always the EF was normal, no diastolic dysfunction, no regional wall motion abnormalities, valve structures look good. There was no thickening, no vegetation seen, and both of these echo were good kind of echo, like good echo as in they had nice windows. There was no interference by anything. So we were confident that, okay, there is no vegetation as such. How he is looking in general. So unfortunately, still the same story that he is diaphoretic. The nausea, vomiting resolved, no GI symptoms at all. The upper abdominal pain is kind of coming down because now the chest pain is taking the centerpiece. Like the chest pain is so profound that, in fact, for 2 days straight, he couldn't even sleep. Like he is lying in the chair for the entire day because of the profound chest pain. Meanwhile, he gets started on NSAIDs, colchicine, and on the day 3 and day 5 of NSAIDs and colchicine, still no improvement in chest pain as such. We obtained the inflammatory markers, so the ESR, CRP, both very elevated. Viral serologies, as you guys had rightfully asked for. So anti-streptolysin O titers, negative. Urine strep, urine legionella, negative. Heptoglobin levels were obtained, unremarkable, so which lowered our concern for hemolysis. And his hemoglobin levels, as Prof. has said, it did come down after hydration, but it was still kind of normal, like 13, 14, 13, 14. And platelets also same, 170, 180. WBC, again same, still leukocytosis, nothing has changed. All the blood cultures, urine cultures are unremarkable. ANA, ANCA, complement levels were obtained all within the normal limits. Anti-phospholipid antibody serologies, anti-glomerular basement membrane serologies, SCL70, all unremarkable as well. Viral studies, so CMV, EBV, DNA negative, CMV serologist negative, toxoplasmosis, IgG, IgM, HHV6 serologist negative, parvovirus serologist also negative. And EBV DNA, as I said, was negative, but EBV serology, so EBV viral capsid antigen, IgG and IgM, both were high titer positive. And at this point in time, I will stop and I will say that a diagnostic test is performed. And one of the prior diagnostic tests, which was sent initially during the hospitalization course, returns back. So with the two tests in conjunction, we are able to make the final diagnosis and we are able to reach the conclusion.
All right. Wow. Now, Kirtan, just a quick question. Did you tell us? So you haven't told us the diagnostic test set, correct? That was sent in the first part. Okay, perfect. So Sharmi, I'm actually not sure what's going on. I'm sure the chat may know what's happening here, but let me just sort of summarize where we are, and maybe together we can get to the bottom of this. But we have a young man who is presenting now, I would say, with more of a subacute inflammatory illness with a signature in the glomerulus in the form of glomerulonephritis, spotty retroperitoneal lymph nodes, and a strong um, footprint on the myopericardium. So we have myopericarditis, we have glomerular nephritis, we have aphthous ulcers. I'm really shocked that we don't have hemolysis, just seeing that AST, ALT, and LDH keep going up. So it still makes me wonder if there is some kind of cell turnover somewhere. The EBV serology being positive, I'm not, I mean, those are very complicated to interpret, and many of us have positive serology. But we do know that you can have like EBV that then stimulates a lymphoma, especially in those individuals that are immunosuppressed in the form of some kind of lymphoma. Charmaine, as I keep talking and I'm extending this, I'm hoping that something lights in your beautiful mind.
Yeah. No, I think it would have been a really the interesting thing is like something will not fit, right? Like I thought it was a really good case for an autoimmune disease like lupus, right? But I mean, we don't have any signature of the lab finding, so that makes it a little less likely. I think the two things that so far I'm still in my mind, one is like something like TB that can mimic. Glomerulonephritis doesn't fit in that for me. However, like everything else from like the pericarditis to lymphadenopathy, splenomegaly, like all of those things, like I think TB can do whatever TB wants to do. And at times, like if it's not a pulmonary TB, it's really challenging to catch. So I wonder if this is someone, I wonder if they had like quants positive in the past, and now they have like a more systemic disease because of the TV that was like unmasked. For what reason, I don't know what triggered it to get unmasked. And the other thing is like lymphoma, that is notoriously can be really challenging to catch, but does explain like the all the inflammations. The glomerulonephritis part, that those dysmorphic reds I have the most challenge with. So I would say like that type of an infection or lymphoma are the top two. So then the question is like, what can you do with a single test? If it's a biopsy, it would be a lymphoma. But I think like in this patient, we have to rule out TB, just like given where the patient traveled from. So that would be my first thing that I would want to do to make sure this I'm not dealing with like TB. What are your thoughts, Raz?
I love that. I think you're absolutely right that TB has to be ruled out. I just have no clue, honestly. Like I'm looking
Yeah.
forward to learning from Kirtan. But I think if I could use GPT and like put stuff into a search engine, I would focus on the myopericarditis. I would include the glomerular nephritis if the nephrologist felt confident in seeing dysmorphic reds. And I would put the young age and the mild splenomegaly and the rising LDH. I feel like LDH doesn't lie, and there has to be some kind of cell turnover. But yeah, I'm not sure. I thought about lymphoma. Lupus would have been great, but that ANA really makes it unlikely. Like ANA negative lupus is very difficult to diagnose. So Kirtan, why don't you shine on us with your sparkle, my friend?
Perfect. So no, you guys are on the right track. and even the chat hinted to the diagnosis. So now let me tell you really authentically that how case evolved, because this really tells you that how we have to keep on trying and how medicine can be humbling. So this case, firstly, was not mine case. So this case was on the floors. I was in some other rotation. One of my friends reached out. They were saying that, hey Kirtan, we have a person who has something in the kidneys, something in the sore throat. We don't know what it could be. I was like, okay. So I told them that order this like 10 serologies which I wanted. They eventually sent it, and still they are cooking. Some of them are still not back yet. And after a few days, I have lost interest. Like I'm doing my own stuff. We don't know. But then somebody else texts me from CCU that, hey Kirtan, do you know there is interesting patient in CCU? I was like, I just saw this patient on the floors and ordered a bunch of stuff. And now he is in CCU, and I got really worried. I went and talked to him. And now, I started thinking again that whatever I sent, let it be, and it will come eventually. And I will tell you later what did I send. But the point is that now how we will reconcile all of this inflammation without any signature anywhere. And what kind of diseases can hide from a really comprehensive workup. Like and even the biopsy, you could imagine that where are we going to biopsy? Because the lymph nodes, we even obtained the repeat CT scan, none of them were prominent enough. So IR said there is nothing to biopsy and there is no signature that this biopsy would be pathognomonic. It would be probably non-specific and reactive itself. So how to reconcile all of this? So first thing regarding kidneys, let me comment on this, that whenever you have so much inflammation going on in the body and your kidneys are just one piece of the puzzle, probably they will not give you the diagnosis. Like let's say even if you do the kidney biopsy, let's say it shows IgA nephropathy. Now IgA nephropathy, there are like 15 things which can cause it. Like 10 infection can cause it, vaccine can cause it, insect bites can cause it, any antigenic stimulation can cause IgA nephropathy. So again, we are back to square one. So we presumed that given that this patient, as Sharmin said, that AKI is not really worsening, so it really can't be RPGN in a sense. So if it's not RPGN and anti-septolizin O titers are negative, complements are normal, then it most likely seems to be IgA nephropathy, because there are not many other diseases which will cause normocomplementemic glomerular hematuria with preserved creatinine. So now our thing was to figure out that what systemic condition could be causing IgA nephropathy. So that is in the background now. And this is how it turned out that, sometimes when we try to employ our cognitive energy at the same time on day one, probably we won't be able to reach the diagnosis. But if we keep on reiterating that process and try to see the case with a different light, maybe something will hit us. So that is what happened in this case, that it was my cardiology floors, and this patient is in CCU, not in the cardiology floors. But at night, I was just looking at the day team's note to see that how this patient is doing with pericarditis and everything. And my intern had wrote this in the note that a young guy with sepsis of unknown etiology, persistent neutrophilic leukocytosis, and sinus tachycardia. So, that framing triggered something in my mind that if it's a young person who has something which started with sore throat and now has this severe inflammation, and inflammation of serosa in a way, right? You have mucosa, you have pericardium as such, maybe pleuritis as well, little bit. Then what could be this? And then I started wondering that could this be adult onset Still's disease? Because if you think of about it, adult onset Still's disease is pathognomonic of sterile inflammation in the body. And if you start looking at the Yamaguchi criteria, you will realize that it's really non-specific. Like so many things can cause hyperosphenomegaly, so many things can cause sore throat, so many things can cause fever, arthralgias, rashes. But when all those so many things you rule out step by step, like biggest one is lupus, you rule it out. What about EBV? So here's the deal that EBV DNA was negative, right? Now, EBV is one of those viruses which always stays in our body. So whenever you have some kind of illness, doesn't matter what illness it is, you will shed EBV intermittently and your IgM titers will go high. So it doesn't really bear any relevance to it. And even if it was EBV, how are you going to treat it? Like it should have dampened it by now, right? So we thought EBV is just a red herring. It's not, it has got nothing to do with anything. So once you rule out all these mono-like illnesses, EBV, CMV, HIV, HHV6, toxo, hepatitis, and COVID screen is also negative, so it cannot be MISA either. Then you start wondering that, okay, Still's disease is a good thought because you ruled out the ANA and you ruled out the rheumatoid factor as well. Now, in Still's disease, there is no diagnostic test, but we know that ferritin, if it's really high, it can signal you towards the Still's disease. Now, we also know that over the years, people have tried to figure out that what's the ferritin cutoff at which you can say this is Still's disease. And to be honest, there is no ferritin cutoff because even ferritin of 20,000 doesn't mean that it cannot be sepsis. It still could be sepsis. But if you look at our patient, there is no sepsis. If there was sepsis, like bacterial sepsis by this time, without receiving any antibiotics, he would have died or you would have caught something. So it is not sepsis. His liver is doing fine, like coags are good, albumin is holding there, which means he is not in liver failure, which is another cause of very high ferritin. His antiphospholipid antibody serologies are negative because catastrophic APLS is also another cause of very high ferritin. He doesn't have lung infiltrates because PJP and histoplasma can cause high ferritin. We don't have that. Cytopenias, tone called normal. No fibrinogen abnormalities. Triglycerides are normal. So with cytopenias being absent, the chances of hemophagocytic lymphohistiocytosis, HLH, is also low. So you could start imagining that you ruled out all other causes of high ferritin. Now only thing which is remaining is stills. So at that night, I went to CCU. I told the team that, hey guys, I think we are at that point that this case could make it or break it. So let's get ferritin. So I ordered the ferritin, and like all night I'm refreshing it. I can't sleep because like this is that one test which is going to give you the final fruit, right? And then the next day the test comes back, it is like 7,500. The next day it goes to 10,000, then 15,000, then 20,000. So it keeps on going high, high, high. And all those cytopenias have always been stable. So this is a very consistent case of Still's disease, right? And then during this time also, my friends like Noah and Marcella visited me from St. Louis. They came. I was telling them this case, and Noah and Marcella also said this, that what about ferritin? Could it be stills or not? I was like, yeah, you guys are on the right path. It could be stills as well. So at this point in time, you start the steroids, you start the tocilizumab, like all the stuff which you do for Still's disease. Patient, as soon as he gets the steroids, the next day his fever's vanished, his heart rate goes down to like 65 or something. He is able to sleep. He's looking amazing, right? So you might think that this is the end of the case, right? But then always this puzzle remains that why all of his friends had the same symptoms. All of his friends had sore throat, nausea, vomiting, diarrhea, but only he got this sick. But how will we explain that profound sore throat and stuff? So this is where that humbling part about medicine comes in, that you have to do the workup and then you see what you get at the end. So while the patient was on floors, I had sent the workup, right? And that workup included, because acute infection, IgA nephropathy, sore throat, you always want to check out mycoplasma. So what I recommended the primary team was to get mycoplasma serologies. And now guess what? Like I get the ferritin. Ferritin is really high. So Still's disease, now it starts coming in the notes. And then on week 2, Sunday. So we are at the 14th day now. Mycoplasma IgM serologies, 3,500 comes back positive. And now everybody like is like going crazy that what is going on. And then I reach out to all the subspecialties, and simultaneously ID, hematology, rheumatology, all three are in the patient's room at the same time. And they are like that, who the hell ordered this mycoplasma initially, and now all of us are working on Sunday morning, what is this? And somebody is like, there is the department of diagnostic medicine who ordered it secretly, and now everybody is going crazy. So eventually mycoplasma was treated as well, azithromycin 5 days course. And this also probably proves that why all the friends had sore throat, because all of them got exposed to some viral infectious trigger at that time. I mean, bacterial infectious trigger, and all of that goes mycoplasma. And if you read about it, we'll find out that adult onset disease always has a trigger. So what Sharmin was alluding in the first aliquot itself, that infection triggering autoimmunity. And EBV and mycoplasma are two big things which can trigger the Still's disease even after the infection has faded away. So that was the final conclusion, that this person had mycoplasma acute infection, which probably explained the sore throat, some degree of bronchitis, and which eventually triggered this systemic Still's disease, which caused the pericarditis, hepatosplenomegaly, ferritin elevation, which explained the AST-ALT rise as well. And the final treatment would be you treat the azithromycin, you get rid of the infection, and for the Still's disease, you give them a prolonged like 6-week course because it was severe Still's disease. You go for steroids. And even the aphthous ulcer mycoplasma we know is known to cause ulcerations and rash, and it has that cutaneous signature as well. So yeah, that was the final conclusion.
Wow, what a journey. Kirtan, you're awesome. And I really, really love how you never stop asking why. So even when it's like, okay, it's It's very, yeah, and it's a really good story for adult onset Still's disease. I just had assumed ferritin is normal, so don't make assumptions in CPS cases. And I think like going back and again like asking why he developed like this severe illness when everybody else didn't. It was a really, really good thought. Catching the mycoplasma. It's really awesome. You are definitely a medicine detective, Kirtan, and it's really, really awesome to uh, have the opportunity to think through this case. And yeah, and I think like for me, like kind of thinking back, I feel like you're absolutely right. Like I think it's still this is a diagnosis of exclusion in this case, and you have to kind of make sure every other disease processes. The one that I couldn't shake was like kind of a lymphoma because again like biases. I've just had like a couple of really sneaky lymphomas hiding from us on service, so I think like that's also I had like recency bias. But yeah, I'm really grateful for this Christmas gift of thinking through this and having the absolute pleasure of discussing with Prof. Rez. Any thoughts, Prof. Rez?
Yeah, I want to say thank you, Kirtan, for bringing this case. I think the reason I mean, in retrospect, when I highlight the neutrophilia, even the hepatomegaly, um, and the fever and the mucositis and serositis, like adult onset stills would really jump on the DDX. But I think that the reason I didn't think of that was because there's so many symptoms in that first aliquot. It was hard to focus on just a sore throat. There were just so many symptoms. And thankfully, people send the ferritin for various reasons, and that would have definitely been a very, very strong clue. But yeah, thank you, Kirtan, for this gift. It was a very good case. And I want to echo what Charmin said, that you kept asking why. And like the link of mycoplasma triggering it is really special. That's really, really cool, man. Thank you for that gift. And Charmaine, thank you for co-discussing. I really enjoyed this hour.
Thank you all. Love VMR. Kirtan, thank you again. I can't, hopefully, it won't be another 5 years. So let's definitely hang up. Please keep coming and teaching us whenever you get a chance. I know you're really busy, and I love the Kirtan consults. I'm gonna start texting you, friend, too. Add me to the list. Thanks again, everybody, for joining us. I'm all great. We're ready for you.
Thank you for the great case, Dr. Kirtan. It was really amazing to go through it and the wonderful discussion. I will rush through the teaching points. We had initially we had multiple symptoms: nausea, vomiting, headache, night sweats. So we thought that these all symptoms could be the bystanders to a systemic process, and we were mainly concerned about the chest pain that the patient was having, which was left-sided epigastric pain. And we thought that the other symptoms are bystanders. The night sweats could indicate inflammation, and in the labs, it was proved by the demargination of peripheral neutrophils as the evidence of leukocytosis and decreased albumin, which is an acute phase reactant. So we thought about the IMAID mnemonic, which has infection, malignancy, autoimmune, drugs, endocrine. And then we also thought that an intracranial process is also a possibility. So we need to be broad with our differentials. And autoimmune, we were considering giving the age of the patient. Then we also saw that the patient had recently traveled, so a fever and returning travel schema also comes into play. And we can consider infections with a long incubation period in this patient. Then we saw that he had raised LDH with normal CBC, which made us think if the CBC is correct. If the patient is dehydrated and the CBC is artificially high, so we were thinking if the patient might be having decreased platelets, so we need to check haptoglobin and smear, and hemolysis is a possibility. So if finally, ultimately, we think hemolysis is a possibility, we can get a Coombs test and then classify into warm versus cold. Then we saw the patient had hematuria plus proteinuria, which raised the concerns of a possibility of glomerulonephritis or glomerulopathy. We thought of trending urinalysis in this case and go for urine microscopy to look for casts, and also spot protein creatinine ratio. We also thought of getting a pan CT scan. And if we think if it's glomerulonephritis, then if it is, we have to consider if it's immune complex mediated or ANCA anti-GBM mediated. So we need to send serologies for that. And we also discussed about glomerulonephritis with normal creatinine. And we learned that one does not need to have acute kidney injury to be diagnosed as glomerulonephritis. And this patient had proteinuria, hematuria, and dysmorphic RBCs. So we thought ultimately that this could be IgA nephropathy. Then we had this patient had splenomegaly plus lymphadenopathy, which raised concerns for an infiltrative process or a granulomatous disease. We thought of getting thick and thin smears for malaria, and the retroperitoneal lymphadenopathy also made us think about lymphoma, and which can actually lead to hemolytic anemia, secondary cause for that. So while we were considering that, the patient developed chest pain, which was worse on lying down, which made us think if the patient is having pericarditis, and an ECG would be important. A POCUS or detailed echo to look for pericardial effusion, TROP-T to check if the myocardium is involved as well. Also, we considered the possibility of esophagitis. So the next test we were considering, given the glomerulonephritis, ANCA, anti-GBM, ANA, and a query with kidney biopsy if discussing, which would be sent after discussion. Then we found out that the patient had normocomplementemic glomerulonephritis with normal creatinine, which raised concerns for IgA nephropathy. Ultimately, we finally discussed the Yamaguchi's criteria for adult onset Still's disease. The points for that are very non-specific, but we can go ruling them out one by one. And before that, we can also rule out various mono-like illnesses, autoimmune diseases. There is no specific diagnostic test for adult onset Still's disease, but ferritin can be checked for that. And after checking the ferritin, other causes of elevated ferritin can also be ruled out. Adult onset Still's disease often has a trigger, which was mycoplasma in this case. And if we discuss about the criteria, it has major criteria and minor criteria. Major, at least two should be present, high-grade fever, which was seen in this patient. Then second is arthralgia or arthritis. Then non-pruritic salmon-colored rash on trunk or extremities. And fourth is granulocytic leukocytosis, which was also seen. Minor criteria could be any of the following: sore throat, lymphadenopathy, splenomegaly, hepatomegaly, abnormal LFTs, and negative ANA-RA. So we ultimately diagnosed the patient as acute mycoplasma infection, forming a trigger leading to the systemic adult onset Still's disease. I learned a lot. Thank you so much.
Wow, how do you do this? That was amazing, Amalpreet. Thank you so much for going through all the incredible teaching. Kirtan, you're awesome. Y'all are wonderful for joining us on Christmas. Thank you for giving us an hour of your time, and all of the chats, everybody who puts their thoughts in the chat. Thank you, Raz. Always grateful for the opportunity to hang with you, discuss medicine with you. Hope you all enjoy the rest of your day. Have a good one. Bye.